Hello and welcome back. So now having covered, peripheral edema due to hypoalbuminemia secondary to nephrotic syndrome, I'll be moving on to an approach to peripheral edema secondary to glomerulonephritis. This will be part 2.1 in the discussion on an approach to peripheral edema. And just to reiterate, the this actually falls under a separate heading, that is it is under oliguric renal failure resulting in peripheral edema. Okay, so and why do I say this? Because I have covered this as a separate heading after in the series on peripheral edema. So as I have described there, this is a cut section through the glomerulus, and these are the hydrostatic pressures that cause filtration through the glomerulus. So this is your mesangial cell, this is your endothelial cell, these are your visceral podocytes, and this is an immune mediated immune cell within the lumen of the capillary. Now, as I described at that point of time, two things can happen within the glomerulus that result in a decreased blood flow through the glomerulus. So one is glomerulonephritis and the other is thrombotic microangiopathy. Okay. And today the discussion will focus on glomerulonephritis. Subsequently, in a few discussions, we'll get to thrombotic microangiopathy. And as I have described it at that in that discussion, the clinical presentation of these disorders has been discussed in detail in an approach to oliguric renal failure. But as you can see, both thrombotic microangiopathies and glomerulonephritis can have, very similar urinary abnormalities. That is, they have increase in RBCs and increase in WBCs and subnephrotic ranges of proteinuria. Now, this is not always the case with nephrotic syndrome. With glomerulonephritis, you can have active urinary sediments and nephrotic range proteinuria, and we'll come to that. But in the next video in the series. But specifically today, I'm going to be discussing uh, the the entity to the leftmost part of the screen. That is, I'll be discussing glomerulonephritis. Now, in subsequent discussions, I'll be talking about microangiopathic hemolytic anemia, interstitial nephritis, specifically acute interstitial nephritis, since this is approach to peripheral edema, and then by both mechanisms that I've described previously. Okay. Now, also I discussed that some basic investigations help us differentiate the different causes of glomerulonephritis, as in hypercomplementemia, thrombocytopenia, leukopenia, eosinophilia, and the presence of increased serum globulins, and indicate specific etiologies. And we'll be delving into this in greater detail in the present discussion. So, these were the things that I had discussed in the previous discussion, and this is where I'm going to start off from again. Okay. But this time we'll be trying to get a more in-depth mechanistic understanding of as to why as to why we essentially have these disorder, why we have glomerular inflammation happening in these situations. Okay, now hypercomplementemia importantly doesn't necessarily point towards a specific pathology, but actually it rather indicates the activation of the complement pathway, and that in turn is there is an alternate complement pathway, classical complement pathway, there is an MBL pathway, then there is what is called the CRP pathway. Okay, so we'll get to that. So the details of that and how it is used diagnostically is what I'll be discussing in part in this discussion. Okay. Now, what I'll be discussing will be this. First, we'll try to understand the different pathomechanisms that result in a common presentation but varied histological morphologies. Okay, so we'll we've covered a part of it, as in we've covered nephrotic syndrome. We'll just delve into nephritic syndrome here. We'll compare and contrast between the causes of nephritic syndrome that are typically associated with, in this discussion, subnephrotic proteinuria, and in the next discussion, nephrotic range proteinuria. Okay, so that will include membranoproliferative GN, for example, but it'll also include your plasma cell dyscrasias related glomerular injury. Now we'll compare and contrast between etiological diagnoses that cause nephrotic syndrome but in this discussion without nephritic syndrome, but in this discussion without nephrotic range proteinuria. So this will include Goodpasture syndrome, post streptococcal GN glomerulonephritis, IgA vasculitis, that is also called hinox purpura in children, subacute bacterial endocarditis, and SLE, related nephritis. Now we'll also review the detailed illness scripts of two of these disorders, that is Goodpasture syndrome and IgA vasculitis or IgA nephritis. I'll be discussing the detailed illness scripts of SLE nephritis, obviously in our discussion on clinical immunology and rheumatology. I cannot do justice to it here. So then we'll try to understand finally what are the sequelae of acute and chronic glomerular injury, in order to understand how that eventually leads to end-stage renal disease or chronic kidney disease. Now, that is just a intro to how that happens. We'll be discussing that subsequently in our discussion on chronic kidney disease. Now, let's start with what is happening. Why is glomerular inflammation happening? So, in the previous discussion, I had shown you this schematic of the glomerulus. The yellow cells are actually vessel podocytes, the green cells are mesangial cells, red is capillary endothelial cells, and the white cuboid cells or columnar cells are rather the proximal convoluted tubule cells. Now, this is the hilum or the vascular pole, and on the other end, we have got the proximal convoluted tubules origin. Okay. Now, in addition to that, we have this is one single glomerular tuft, and you can see there is a capillary and there is a capillary branch that is entering into it, and there is a it's not a venule, it's still a capillary, but there is a vessel coming away from it. Okay, so now this is what it looks like under the microscope, and we've discussed that this is the vascular pole. Okay, the other end you got the tubular pole. Uh, these are the glomerular capillary tufts that I have shaded. And now what I'm going to do is I'm going to take a cut section through one single capillary capillary loop. Okay, and enhance it in size and try to demonstrate how glomerular changes affect it. But remember that we'll have to reverse engineer all of this in order to understand the histopath in the next discussion. Okay, so this would be the mesangial cell. um, the next cell is the endothelial cell, and then we have the visceral podocyte. So it's a visceral podocyte, and inside we've got a polymorphonuclear cell or a macrophage, one of the two, mononuclear or polymorphonuclear cell. Okay, so this is be the schematic that we'll be using, but remember this represents one single cut section of one single capillary lumen. Okay, within a tuft, which four or five tufts together form a glomerulus. So this is a small part of the small part of the glomerulus. Okay, but this is useful in understanding the mechanisms of glomerular injury, and then we'll in the next discussion extrapolate this to understanding how would this would result in histological morphological changes, and which form a central point in our diagnostic evaluation of glomerulonephritis. Okay, so this will be used as visualization aid. Okay, so this is what we will be starting off with. Now, uh, basically, glomerular injury can occur because of three mechanisms. First is type 2 hypersensitivity, that is, an antibody is deposited against an in situ antigen that is already present within the glomerulus. So, the prototype of this is Goodpasture syndrome. And then, second one, we have got type 3 hypersensitivity. We'll discuss there are a lot of disease disorders there. Type 3 basically means an antigen antibody complex is formed in serum. Okay, so there's an antibody, an antigen binds to it, and then this complex is then deposited within the glomerulus secondarily. Now, this kind of deposition can be, as you can see, either mesangial, as I've shown in this diagram, or it can be subendothelial. Okay, so I don't know if it's very clear, but here it is on the endothelial side of the basement membrane. So you got your basement membrane, then you have your visceral podocyte. Okay, forming the slit membranes. Okay, and you have your endothelial lining. So this is your endothelial lining, and the deposits are actually here in between the endothelial lining and the glomerular basement membrane. Okay, so that is your one mechanism of type 3 injury, type 3 hypersensitivity. Then you have something called ANCA vasculitis or ANCA anti-neutrophil cytoplasmic antibody mediated injury. So here what happens is a rather interesting process, that is you got an antibody against neutrophils. Now, this antibody goes and activates a cell. It does not go and get deposited. It directly activates a activated neutrophil, and how the specifics of that and why that is important we'll talk about later, or what in we typically call a primed neutrophil. So the antibody binds to this, and then the FC region of the antibody, or the tail end of the antibody, activates a receptor on the neutrophil for that FC receptor, and then that results in more neutrophil activation. So it's actually the neutrophil that is getting activated in serum, that while it is circulating, and this then enters into the glomerulus. So say this is the neutrophil that is entered, and then starts causing damage to the glomerulus by releasing enzymes and producing reactive oxygen species. So that is what happens in vasculitis. Okay, so this is typically a very florid reaction, and because of that, there are there's significant structural damage that occurs within the glomerulus that causes a lot of leakage of these inflammatory proteins and growth factors produced by the local endothelium, like platelet-derived growth factor and your vascular endothelial growth factor, and that leaks into the Bowman space. So this is obviously the Bowman space, and that then secondarily causes a hyperplasia, or increase in cell number, or proliferation of the parietal podocytes. So this is the Bowman's capsule parietal podocytes, and they start proliferating, and that forms a bridge between the conglomeral capillary tuft and the Bowman's capsule, and that is what you're seeing there. So this we under the microscope call a crescentric gene, because this produces a subcapsule. So this being the capsule, a crescent of cells beneath the capsule. Okay, and this correlates with a histological entity called rapidly progressive glomerulonephritis. Okay, so they're not exactly the same thing, but for most purposes, that is what is implied, causing confusion naturally. But I like to call it crescentic GN too, because then you know that I'm referring to the histological morphology. Um, RPGN could be in turn any three of these entities. Now, interestingly, uh, Goodpasture syndrome can also have the same effect. It can cause so much damage that again there is leakage of these inflammatory proteins and growth factors into the Bowman space, causing this kind of subcapsular crescentic proliferation. So the morphology can be exactly the same. So the only way actually to differentiate this is how I use the immunohistochemistry. So I see where the antibody has gotten deposited. So in ANCA, like I discussed, the antibody is activating neutrophils, and neutrophils are secondarily causing the damage. The antibody is not getting deposited. So if I look for antibodies in the glomerulus, I will find nothing. So there is no deposit in ANCA vasculature related glomerulonephritis. Whereas in case of your Goodpasture syndrome, you have a antibody getting deposited and along the basement membrane. So I'll use a red color here, along the basement membrane, like this. Okay. And when I use immunohistochemistry, the antibody is now exactly along the basement membrane. So what I get is a linear pattern. Okay. So I get a linear pattern. So these are the two things that are very clear. Now, please remember, again, type 3 hypersensitivity can also be very, very severe. Okay, so then type 3 hypersensitivity can also be extremely severe and can result in crescentic gene. So as you can see, all three types of mechanisms, depending on their severity, result in crescentic gene. It is just that ANCA is quite likely to cause it. Similarly, anti-GBM is quite likely to cause a crescentic presentation, but crescentic gene is specific for none of these. And actually, crescentic gene is clubbed under the histological, umbrella term RPGN, or rapidly progressive glomerulonephritis. And then RPGN is subdivided into type 1 Okay, this is not relation in relation to the mechanism. This is just a numbering. Okay, so then type 2 and type 3. Okay, RPGN. So as you can see, I uh, I know the terminology is a little confusing, so maybe you can go over the video again if you have any confusion, but I hope that is clear. Okay, so the inclusion of these entities under the heading of rapidly progressive glomerulonephritis is based on their presence of cricentric gene. So you start from the histology, okay, which is not what we do clinically. We go from clinical presentation to histomorphological analysis. But obviously, this is a classification made by pathologists. So they start with histomorphology. And so the what is common among these disorders is that they can all cause a cricentric GN or this subcapsular crescent formation. Okay. But the mechanisms underlying are of three types. That is type 2 hypersensitivity, type 3 hypersensitivity, and ANCA associated glomerular damage. And therefore, when you do immunohistochemistry, the pattern of immunohistochemical staining is very different. In case of type 2 hypersensitivity, it is a linear basement membrane staining. In case of type 3, it is a granular staining, that is, it's patchy and subendothelial. And then you have ANCA where there is no staining. Okay. Now, uh, yeah, so subendothelial deposits can also cause enough damage to cause concentric GN, and this can only be again differentiated based on histomorphology, based on immunohistochemistry. Okay, so that basically leaves us with three mechanisms of glomerular injury. The first being type 1 type 2 hypersensitivity, second being type 3 hypersensitivity, and then finally we've got ANCA associated glomerular damage. And as we've seen already, the IHC in case of type 2 hypersensitivity is linear. In case of type 3 would be granular, and in case of ANCA it would be there would be nothing on IHC. Now, see, linear only there's only one disease that comes with this, that is Goodpaster syndrome. In case of granular, we can divide the disorders based on their serum complement levels. So you could have low complement levels and you could have normal serum complement levels, uh, or just an isolated reduction in C3 complement. Now, low complement classically has been described in post and para-infectious glomerulonephritis. Okay, so post-streptococcal glomerulonephritis is the most uh, typically discussed under this heading, but actually this includes a wide variety of infections. So it can be a post-streptococcal GN or any other infection related GN. Then it can be hepatitis B or C virus related glomerulonephritis. It can be subacute bacterial endocarditis, syphilis, and schistosomiasis. In addition, you could have low complement in membranoproliferative GN and C3 GN, which will be discussed in the next discussion, as I've previously alluded to. And you could also have it in cryoglobulinemic glomerulonephritis, SLE, as well as malignancy associated paraneoplastic glomerulonephritis. Now, normal complement levels and decreased C3 isolated C3 hypocomplementemia seen with IgA nephritis. It can also be seen in subacute in post-streptococcal glomerulonephritis, and we'll see how that happens. Now, in case of ANCA vasculitis, there's just ANCA associated, so it can be P or C ANCA associated. C stands for cytoplasmic and P stands for perinuclear. So your C ANCA is also anti-PR3 ANCA, it is proteinase 3, and P ANCA is also anti-myeloperoxidase ANCA. So C-ANCA actually is associated with granulomatosis with polyangiitis, and P-ANCA is associated with eosinophilic granulomatosis with polyangiitis and microscopic polyangiitis. All three of these obviously are ANCA-associated vasculitides. Now, coming into the meat of the discussion. So, now we're going to discuss the glomerulonephritis resulting from the deposition of immune complexes in the either the as mesangium and or the subendothelium. This includes getting deposited within the basement membrane. So this diagram shows these red dots represent the immune complexes deposited, and here in this first diagram they are deposited within the mesangium only. In this second diagram, you can see they are deposited in the mesangium and in a subendothelial location. So it's deposited here, it's subendothelially. Okay. Um, so there are actually five diseases that I'm going to compare head to head. This table is rather exhaustive, but it helps clinically because these are the entities that that we consider together, and it is fruitful to compare them head on to each other. Now, the first entity is Goodpasture syndrome. Second will be post-streptococcal glomerulonephritis as a stand-in for post and para-infectious glomerulonephritis overall. Then IgA related glomerulonephritis, subacute bacterial endocarditis related glomerulonephritis, which is again a para-infectious GN, and systemic lupus erythematosus related GN. So we'll first talk about the patient demographic profiles. I typically use the mnemonic graph, that is gender, race, age, and family history. So we'll be following that pattern. In terms of gender, Goodpasture syndrome tends to present tends to have two peaks, and within those two peaks, the gender distribution is slightly different. So when it presents in younger individuals, you got a male dominance. When it presents in older individuals, there is no male dominance. It is equally distributed among men and women. Um, Post-streptococcal glomerulonephritis and IgA glomerulonephritis are more common in men than in women, although individual data varies, and so different studies quote different values, but overall it is male dominant. Then subacute bacterial endocarditis, it depends on the epidemiology of infective endocarditis, and in the post antibiotic era it is actually exceedingly rare, with the exception of Q fever, chronic Q fever being one case in which you might get it. Then we have SLE, and SLE obviously shows a strong female dominance. Then we've got racial predilection. So, Goodpasture syndrome is a very rare disease and therefore does not show any reproducible racial predilection. Post-streptococcal GN again does not show any racial predilection. IgA glomerulonephritis has been described in the Asian and Pacific Rim region. So the Pacific Rim region is the ring of fire that extends from Japan on the east, you know, through the Kamchatka Peninsula across Alaska, then northern North America and South America, rimming around the rather the Pacific Ocean. And it has also been described at a slightly elevated rate in southern Europe. That would be Italy and Greece. Okay. It is much lower in North America and Europe. And this is data that is quoted in Harrison, 22nd edition. So, factually important to know. In SLE, we'll discuss the racial prediction and distributions in SLE in great detail. So, I'm not going to go into that right now. So, like I said, in Goodpasture syndrome, there are two peaks. The younger peak is in patients usually present in the late 20s, and older patients present at typically older than 60 years of age. Post-streptococcal glomerulonephritis classically was described in young children between 2 to 14 years of age. However, with the rampant use of antibiotics over the counter, usually in developed countries, it is typically described in elderly individuals. Now, IgA nephropathy is a disease of childhood. Even overall, IgA nephropathy is 95%, less in present in children, less or people younger than 20 years of age. But yes, around 5% of people can be up to 30 years of age. Okay. As age increases, the likelihood of development of IgA nephropathy, glomerulonephritis decreases. This is because if you have a genetic predilection for it, you would have developed it by that age. Okay. And then we'll be getting into the details of that subsequently. Again, subacute bacterial endocarditis. Uh, the epidemiology is variable because it reflects the epidemiology of infective endocarditis, and also different people have different genetic predictions for development of endocarditis, and are treated differently when such a situation arises clinically. Now, SLE typically is said to start between 25 to 55 years of age. Now, to be fair, this is not true. SLE can occur at any age. After 55, we call it late onset, and before around 16, we call it juvenile. So, again, juvenile, the younger the patient is, the higher the risk of developing glomerulonephritis. But certainly, elderly ladies, at least in my personal experience, do develop glomerulonephritis. Um, okay. Now let's talk about the family associations, and the chronological relationship of the development of glomerulonephritis to exposure to particular precipitants or triggers. So, in case of Goodpasture syndrome, there is no significant family history. Post-streptococcal, because it is an infection-related disease, and that infection is airborne, family and cohabitant incidence is reasonably high in some data, so up to 40% concordance. IgA is not really, even though it is likely genetically mediated, it is not universally in all data considered to be, have to be inherited in a family. However, there is some data from northern Italy as well as eastern Kentucky. So as I discussed earlier, it is more common in southern Europe. So that is one, again, a factual thing that one needs to recall for exams. Um, Now, SLE and subacute lupus are not obviously subacute bacterial endocarditis does not have a genetic prediction, and SLE may, but again, there's a lot of nuance there. So for now, we'll leave it at we'll not comment on it. Now, Goodpasture syndrome develops simultaneously with exposure to specific precipitants. That is, exposure to smoking, exposure to oxidants, infections of the lung, particularly, and exposure to inhaled solvents. Okay. Post-streptococcal glomerulonephritis has a lag, and this is often, highlighted in MCQ questions regarding, patients who've developed glomerulonephritis or nephritic presentation. So the duration from the onset of pharyngitis is the critical point in determining the answer to the question. So in case of post-streptococcal glomerulonephritis, it is usually a gap of 1 to 2 weeks. Now, post-streptococcal glomerulonephritis can also develop, although at a lower rate, after skin infections with streptococci. That means after impetigo. So here the gap is actually much longer. That is 6 to 8 weeks. Um, Now, IgA glomerulonephritis can occur like good pasture. The nephritis can develop at the same time, or it may develop within 1 to 3 days. Okay, so in these two situations, the term synpharyngitic is often used. Synpharyngitic. Okay, and synpharyngitic basically means occurring along with the onset of a epithelial infection. So in this case, pharyngitis. Um, Subacute bacterial endocarditis usually occurs 10 to 14 days after the onset of fever. So that is why it is subacute. Okay. The fever, heralding the development of infective endocarditis. And this is much more likely to occur, like I've discussed just earlier, with untreated cases with culture negative infective endocarditis, which would obviously could be Q fever and brucella, and also with right-sided infective endocarditis. So these are the three situations in which you get it. SLE, again, there is often infectious agent that coexists with SLE, but there's a lot of the dynamics of SLE and its precipitation are quite complex. So we'll discuss that at a later date when we delve into SLE in detail. Okay. Now, what are the patients that develop? Who are the patients that develop these particular disorders? And obviously, as we have already discussed, there are some serological markers that we use to diagnose these disorders and start treatment prior to the availability of the renal biopsy, because the renal biopsy is likely to take some time to come. Now, Goodpasture syndrome actually is very rare, so it has no reproducible risk factors. Post-streptococcal glomerulonephritis naturally is obviously it always triggered by a streptococcal infection, either pharyngitis or impetigo, but much more commonly pharyngitis. IgA glomerulonephritis can be induced by any epithelial infection, and like I just mentioned, it is usually classically said to be synpharyngitic, as in occurring in coinciding with the development of pharyngitis. Subacute bacterial endocarditis, I use a mnemonic that is device. D, E standing for diabetes mellitus. V standing for valvular heart disease. I for IV drug abuse, and C for hepatitis C. In this, hepatitis C is what you would not expect. So that is actually a factual question that would be asked. Now, when it comes to serology, uh, I'm going to first discuss the presence of rheumatoid factor, ANCA, and cryo. So none of these disorders are ANCA vasculitis. So you do not expect ANCA in any. Okay. Again, these are not, it's not rheumatoid arthritis, so you don't really expect RF. Okay, and unless I am specific, I'm not specified cryoglobulinemia vasculitis, so I also do not expect cryo in any of these disorders. But all of these disorders can, at a minority of the patients can have these three antibodies in their blood, their serum, and that causes diagnostic confusion. So that is why it is prudent not to hinge your diagnosis completely on serology. Now, importantly, Goodpasture syndrome, around 10 to 15% of cases have coexistent ANCA, and these are true ANCA vasculitis. Okay, these are not Goodpasture syndrome with false positive ANCA. This is true ANCA vasculitis. Incidentally, data does indicate that the prognosis of such patients is slightly better, although that may have something to do with treatment variations in treatment in these patients. That is a topic for a later discussion. Now, again, whenever you have an infection, certain antibodies like anti-immunoglobulin antibodies like RF, okay, or anti-neutrophil antibodies or cryo, they tend to increase in a, in a as a result, as a result of a non-specific activation of the of B cells, and that results in elevations in RF titers, in ANCA titers, and in cryo. So post-streptococcal pneumonitis is notorious for this. Okay, so we'll see the most telling thing is that cryo is decreased in post-streptococcal. Sorry, I mean rather complement levels are decreased in post-streptococcal pneumonitis. Now, once the complement levels are low, you are no longer thinking of ANCA vasculitis. So those 10% cases where ANCA is low titer positive, they don't carry any weight. Similarly, now it could be cryo, and technically it would still be called cryoglobulinemia vasculitis. We would just call it, post streptococcal glomerulonephritis with cryoglobulinemia. And RF positivity occurs because part of in type 2 cryoglobulinemia vasculitis, you get RF positivity. So that is why it is there. Again, these don't carry much value. What is important is the hypocomplementemia. Okay. Now, but it is important to know because otherwise you'll get confused. Now, importantly, IgA glomerulonephritis never has RF positivity. It does, however, have ANCA positivity and cryo positivity rarely. Okay. So again, ANCA can be false positive in all three of these disorders that I have just discussed, but that is a uncommon thing. And the higher the titer, the more likely it is that it is ANCA, and lower the titer, less likely it is. Okay. Now, in subacute bacterial endocarditis, the distribution is essentially the same as that in post-streptococcal glomerulonephritis because both of them are, post and para-infectious glomerulonephritis. And in SLE, you can rarely have positive RF, that is to be expected. Again, cryo can also be positive. Importantly, ANCA can be positive, and this has an important therapeutic implication, and we will get to that when we discuss SLE glomerulonephritis based on some recent data that has been published. Now, again, complement is decreased in these in post-streptococcal pneumonitis, and it is decreased in subacute bacterial endocarditis as well as SLE. It is not decreased in IgA and good fasting in most situations. Okay, so once I see a patient who may have nephritic syndrome, my first diagnostic branch point is usually serum complement levels, and that when it is decreased, I am pretty sure that the patient does not have good pasture and does not have IgA. Okay, when it is not decreased, then I am considering good pasture and IgA. So these two come together and the other three come together. When it comes to analysis of complement, hypocomplementemia, that is combined C3 and C4 complement reduction, occurs in all of these three disorders because what is happening is in post-streptococcal pneumonitis, in subacute bacterial endocarditis, and in SLE, there is deposition of IgG immunoglobulin containing immune complexes within the subendothelium and the mesangium. Now, these deposits, these antibodies activate classical complement pathways, and that classical complement activation results in usage up of both C3 and C4. Okay. Now, in case of IgA, the IgA deposits can only activate alternate complement pathway, and alternate complement pathway, as we all know, uses up C3 and not C4, and the result is that you would suspect that there would be an isolated reduction in C3, but usually, and this is what you'll find in literature, that the complement levels are normal. And the reason for this is that actually, when alternate complement gets activated and C5a complement degradation product is produced, neutrophils infiltrate into the tissue, and those neutrophils in turn secrete. They are a primary source of secretion of C3, and therefore it is that C3 that is used up and not serum C3. No, therefore, usually the blood C3 C4 levels remain normal. So this is an important consideration. So if you do find C3 levels to be normal, that does not necessarily rule out IgA nephritis. Okay, so what is more important is that when you have a reduction in complement, if it is isolated C3 reduction, it is IgA glomerulonephritis. Okay, but a reduction in complement strongly indicates these three pathologies. Okay, we'll just get to that in detail in the next slide. Now, next is in Goodpasture syndrome, IgG is deposited against in situ planted antigens. Okay, so there is very little classical complement activation in serum. So in GPS, you would GPA, you would in Goodpasture syndrome, you would not expect any reduction in serum complement, and that is what generally happens. Okay, so again, like I said, if complement is low, think of these three entities, that is PSGN, subacute bacterial endocarditis, and SLE. If complement is normal, think of Goodpasture syndrome and IgA glomerulonephritis. Especially if C3 in isolation is decreased, think of IgA glomerulonephritis and also post-streptococcal, and we'll just come to that. Okay, how serum complements differ among these five pathologies. So basically, as you would expect, Goodpasture syndrome, C3 C4 levels are normal. In post-streptococcal glomerulonephritis, hypocomplementemia is almost universal in present in 90% cases, but you have a reduction in C3 and interestingly not in C4, and we'll see why that is the case. IgA nephritis, glomerulonephritis almost exclusively has normal complement levels, and your subacute bacterial endocarditis and SLE almost universally have decrease in complement levels. Now, in subacute bacterial endocarditis as well as SLE, it is both C3 and C4 that are decreased, and in post-streptococcal glomerulonephritis, you have a isolated reduction in C3, and this is a little counterintuitive. We'll get to it. Now, when it comes to specific pathologies or specific antibodies, obviously in Goodpasture syndrome, you have your anti-GM antibodies. These are specifically against the non-collagenous or NC1 region of the type 4 collagen that is present um, in the basement membrane. Okay, and then we have obviously in post-streptococcal antibodies against components of the streptococcal pathogen. So anti-streptolysin O, which is a toxin produced by your streptococcus gamma hemolytic streptococci, and anti-DNase as well as hyaluronidase. And these are the respective percentages. So most commonly it is anti-DNase, then around 40% is hyaluronidase, and about 30% are anti-ASO positive. Obviously, this varies from patient to patient, but overall this is the trend. Now, in SLE, you get SLE specific serology, and importantly, in IgA, we do not measure serum levels. Okay, so do not cause increase in serum IgA. That is a very important thing to understand. We'll see that in detail just subsequently. Now, other investigations that one might do, specifically, you can do a post-streptococcal, in case of post-streptococcal glomerulonephritis. If the patient has come early enough, you can do a swab of the throat or of the skin lesion. And depending on the chronology of when the patient is presented, the sensitivity actually varies. It may be very low in cases in late presenting cases, and up to 70% in early presenting cases. Now, in case of subacute bacterial endocarditis and SLE, you usually also have a normocytic normochromic anemia and elevation in ESR. Now, see, the reduction at the normal C4 in case of post-streptococcal glomerulonephritis is a little bit I would say unsettling. Okay, so the thing is that post-streptococcal glomerulonephritis is due to IgM and IgG antibody deposition, and IgM and IgG antibodies activate the classical complement pathway. The classical complement pathway uses up both C3 and C4, so you should be experiencing a reduction in both C3 and C4, but for some reason the C4 here appears to be spared. Now, actually, if we measure, how much C4 has been activated, which we do by measuring the ratio of C4D to complement factor 4, C4, you actually find that a lot of C4 has been activated, but the serum levels of C4 per se are not decreased. Okay, and the reason for this is that actually the C4 is a and C3 both are your acute phase reactants, and they're produced by the liver during acute inflammation under response from interleukin 6, interleukin 1 beta, and TNF alpha. And because of that, the serum levels of C4 increase a lot. And because they increase a lot, the increased usage up or increased catabolism of C4 does not result in a reduction in your C4 levels. Okay. Now, this is okay. I can understand that. But shouldn't that also apply for C3? So there's a little bit of nuance there. We'll get to it in the next slide. Okay. Uh, okay. So both, since we measure C4 and both its secretion and consumption are increased, we eventually result there's normalization of the C4 levels. Okay. Now, subacute bacterial endocarditis and lupus are much more slowly developing pathologies, as the names suggest. Thus, the C4 usage usually exceeds the increased production that has occurred during the acute phase. So, usually after the acute phase, it starts to fall. So, at that point, the consumption of C4 exceeds the production of C4. So, as a result, you get a reduction in C4. So, importantly, subacute bacterial endocarditis and specifically actually cryoglobulinic when there is cryoglobulinic vasculitis, because the IgM activates a lot of complement in blood also. Okay, and SLE both are conditions in which you can get an isolated reduction in C4 levels, and this is because the usage of a C4 is happening in blood, and the hepatic production of C3 and C4 has actually initially increased, but now it has decreased because the pathology has been going on for so long. Okay, so I'll try to make this a little bit more intuitive in using the following slides. So basically, in order to use this diagnostically, we need to understand how C3 and C4 are produced and how they are catabolized. So we know that when it is alternate pathway activation, okay, that means any pathology that is due to IgA would result in alternate pathway activation and therefore should result in a decrease in C3 only. And when you have IgG or IgM production, that will activate the classical pathway, and the classical pathway activation will result in a reduction in C4 plus reduction in C3. This is what we would expect if the production of C3 and C4 don't change during this process. Okay, this is the expected pattern. Now, however, we'll see that C3 and C4 are actually acute phase reactants, and because they're acute phase reactants, they are produced by the liver, and they are also produced within tissues where the activation is occurring by some cells. So, both are produced by the liver as acute phase reactants in response to interleukin 6. So, their production initially increases a lot and then tapers off, okay, as time goes by. So that is how the liver produces it. Now, in tissue, initially C3 is produced in large amounts. This is by infiltration of activated neutrophils. Okay. Now, later on, a lot of C4 is produced. So this is because professional antigen presenting cells and mast cells come in and they start producing C4. So in tissue, initially it is C3 and later it is C4. So initially this would spare serum C3. So initially you would expect a reduction in C4 if the liver is not able to compensate, and later on it would spare C4. So you would see a reduction in C3 if the liver is not able to compensate. Okay, so we'll see how this is happening. Okay. Now, as we've just discussed, your C3 and C4 are consumed by the classical and MBL pathways, and the alternate pathway only consumes C3. Okay, so what I like to do is I like to visualize it using this graph. So this graph shows time versus the concentration of production of C3 and C4 from different cell types. Okay, so yellow represents the hepatocyte or the liver's production of C3 and C4. So as you can see, as I've shown you just sweeps up previously, C3 and C4 initially rise a lot, and as disease progresses, they taper off. Okay, so this is the hepatocyte production, hepatic. Okay. Now, after that, we have the tissue production of C3. Now, neutrophils only produce C3; they do not produce C4. So initially, C3 is produced by the neutrophils, and so now we've got C3 being produced in tissue by neutrophils, and we've got C3 and C4 being produced into serum by your what is it called, by your liver, by the hepatocytes. Okay, so now say you have alternate complement activation. Now alternate complement activation is going to use up only C3. Okay, so now the thing is, this C3 reduction that would have happened is counteracted by this elevation in C3 levels otherwise. So as a result, usually with alternate complement pathway activation, unless it's very florid, you actually have normal serum complement levels. Okay, that is why IgA nephritis or vasculitis typically has normal serum complements. Okay, because the increased C3 utilization is being counteracted your by your increased hepatocyte as well as tissue neutrophil C3 production. Okay, now subsequent to that, however, what we find is that gradually the tissue, antigen presenting cells start producing C3 and C4. Okay, and this is predominantly C4, not C3 predominantly. Okay, so now we've got a lot of C4 being produced in the tissue. Okay, but the amount of C4 that is being produced by the liver is decreased, and as such, the C3 levels have fallen down. So the C3 production is decreased. Now, if you have an alternate complement activation that is happening, this is going to cause definite reduction in C3 levels. Now, the issue is, however, that we don't get such a alternate complement activation. There is no such chronic alternate complement activation. What we do get is a chronic classical complement activation. So classical chronic complement activation occurs in later stages of post-streptococcal glomerulonephritis or any infection associated GN. So in that situation, what ends up happening is that there is consumption of C3 and C4. Okay, both are tending to decrease, but C4 is being produced into serum. So because it is being produced into serum, this goes away. So you have only an isolated reduction in C3. So now I hope it makes sense to you why in post-streptococcal glomerulonephritis specifically there is a reduction in C3 sometimes and not a reduction in C4. Okay. Now the converse of this may also happen. So when does the converse of this happen? It happens in cases of as I just discussed, in case of SLE and in case of cryoglobulinic vasculitis. And the reason for that is that SLE and cryoglobulinic vasculitis both have a lot of complement activation happening in serum. Okay, and in serum, the source of C3 production is predominantly your hepatocyte, and because these are chronic processes, hepatocyte C3 C4 production is gradually falling down. Okay, so as hepatocyte C3 and C4 production is gradually falling down, that C3 and C4, so you would expect that there would be a reduction in C3 and C4, and as a result of that, you would have both C3 C4 hypocomplementemia. However, because of your antigen presenting cells contributing a little bit of C3 in tissue production, so in situ tissue production of C3, you end up getting a reduction in C4. Okay. So it's a little complicated, but the final analysis is this. So if you have a combined reduction in C3 and C4, what you get is a reduction is a you what that implies is that there is a activation of a classical as well as a complement pathway. So yeah, classical as well as alternate complement pathways. It could mean just isolated classical complement pathway activation also. Okay. Now on the other hand, if you have a reduction in C3, you have a reduction in C3 and you have normal or elevated C4 levels, then naturally we are suspect that C3 utilization is increased. Okay, so that isolated happens in alternate complement activation. However, it also happens with late stages of your classical with classical plus alternate complement pathway activation. Like we discussed, this would specifically entail a post-streptococcal GN or more than other infection associated GNs, glomerulonephritis. Okay, Fine. So this is just basically means that this process has become chronic. Okay. So as a result, now the hepatocyte and neutrophil production of C3 and C4 has fallen down, and antigen presenting cells primarily produce C4. So the C3 levels can no longer be compensated for. Consumption can no longer be compensated for. Therefore, C3 is falling, but C4 levels are normal. Okay. Now the next situation that might arise is you have a reduction in C4 and you have a normal C3. Okay, so a decreased C4 with normal C3 can happen when you have an isolated classical pathway activation in blood or in serum. Okay, so this obviously occurs with cryo and SLE, and this is SLE and cryoglobulic vasculitis. And you can have actually normal C3 as well as C4, and just because you have normal C3 and C4, that does not mean that the patient does not have complement activation. So in this situation, we can use alternate measures of complement activation, as in we can use the patient serum and then we can use it for hemolysis of RBCs, usually guinea pig RBCs, and that the 50% of that RBC lysis can be measured in terms of time. So that is called a complement hemolysis 50 assay. And we can also measure C4D production. As I discussed, C4D is a degradation product of C4. Okay, so just to reiterate, uh, again, if both are decreased, it is a combined classical or alternate pathway defect. If C3 is decreased in isolation, then it is an alternate pathway defect, or it can also happen with post-streptococcal GN and in other infection associated genes later in their course. If C4 is isolated, is decreased in isolation, then that indicates there is classical pathway activation with primary activation occurring in the serum itself. So it is SLE and cryo. And even if C3 and C4 are normal, that does not mean that the patient does not have complement activation. There are other assays that we can do. Now I'm going to discuss in detail two of the pathologies that I've just discussed, the illness scripts of these pathologies. But before that, we'll just talk about anti-GBM and post-streptococcal GN and their miscellaneous considerations related to them. So one is that anti-GBM glomerulonephritis, much like ANCA, can present as a pure renal disease and nothing else. Okay, now, whereas post-streptococcal glomerulonephritis, even if the patient has been treated with antibiotics, it does not decrease the possibility of a post-streptococcal glomerulonephritis, because post-streptococcal glomerulonephritis is an immune-mediated response against the bacteria. Okay, so killing the bacteria is not going to get rid of the antigens of the bacteria. Okay. Now, the other thing is that in case of anti-GBM antibodies, we need to be sure that the anti-GBM antibodies that we are detecting are detected using an assay that does not use a whole glomerular basement lysate. Okay, this is because we specifically need antibodies that target the NC1 region of the alpha 3 chain of collagen type 4. Okay, because other antibodies can develop even in paraneoplastic cases. So in paraneoplastic. Okay, sorry for the. So even in malignancy associated cases, you can have anti-GBM antibody false positivity in blood. Now, the other thing is post-streptococcal pneumonitis can progress over to your membranoproliferative GN, and therefore you can get nephrotic range proteinuria. And this is obviously a discussion of our that will be our next discussion in this series. This is much more common with adult cases than it is with childhood cases, and that is around 20% of adult cases versus around 5% of childhood cases. Okay, so having gone over this, I'm just going to start off with our discussion on anti-GBM syndrome, and then I'm going to discuss regarding IgA nephritis. This is going to be a discussion of illness script, so I'll be a little rapid with it. This is your normal glomerulus, but you can see that there is a deposition of antibodies against the basement membrane all around. Okay, so this is your anti-GBM glomerulonephritis schematically. And as you can see, that has caused a lot of damage to the glomerular basement membrane, as because of that, proteins have leaked into the Bowman space, and because of that, there is a parietal podocyte hyperplasia. Now, I'm going to compare anti-GBM to post-infectious GN, and you'll see why. Okay, and specifically, this is post-streptococcal GN. There are reasons. I'll come to that. Now, the genetics of anti-GBM syndrome, it is a disease that is associated with a specific HLA haplotype, that is HLA-DR2. Okay, so this is a serological haplotype. That is what we need to understand. It's not the gene name itself. Whereas post-streptococcal gene is associated with HLA-B12 and HLA-DEN9. Okay, this is from older studies. Uh, okay, so these are both specifically serotypes, not the gene sequencing. This is because earlier studies on HLA haplotypes used to classify HLA haplotypes based on the antibodies produced when such cells were injected into other mammals, and then though they were numbered according to the slight differences in the structure of the antibody. So they do correlate with some genotypes, but they don't necessarily they are not exactly the same as say HLA-DR B10201. Okay, so there is a correlation, but there is no, it's not the same. Now, what exactly is happening in anti-GBM? Now, this is a very important point that I want to highlight. See, anti-GBM syndrome is a conformopathy. So, what happens is normally you've got a folded protein, okay, which has got a NC1 or a non-collagenous region that is actually within the rest of the collagenous part of the protein. It is not exposed outside. Okay, as long as the conformation of the protein is normal, the NC1 region is not going to be exposed. But what ends up happening is because of some reactive oxygen species exposure or due to some stress, local infections, you end up getting a change in the conformation of the alpha 3 subunit of collagen type 4. Okay, and that exposes your NC1 region, and that and exposure to of the NC1 region results in the exposure of a new epitope that is never normally expressed in normal human tissue, and therefore while during development, developing thymocytes have not been negatively selected against it, so you have some thymocytes that can potentially develop an autoimmune reaction against this new epitope, and that does happen. So as a result of that, you develop antibodies that then go and get deposited in the basement membrane, and you get a type 2 hypersensitivity. Whereas post-streptococcal GN is a type of molecular mimicry. Okay, so what is happening is that the streptococcus, specifically gamma hemolytic streptococci, have a protein called the M protein, which causes development of, which is a lipoprotein, it binds to lipids, and that results in development of antibodies that cross react with human lipid and protein combinations. Now, uh, okay, so specifically it is against the streptococcal pyogenic exotoxin B also, and then there is nephritis associated plasminogen receptor. These are the two basement membrane target antigens against which the antibodies cross react. Okay, the names are important, that's why I've highlighted them. Now, in what ends up happening is because of this, now you have your antibody and bound to it a circulating antigen, that is one of these two proteins, either a streptococcal pyogenic exotoxin B or nephritis associated plasminogen receptor. And then this complex then gets deposited in the basement membrane. As we have discussed, it gets deposited in the basement membrane subendothelially. So if this was the podocyte membrane and this was the endothelium, it gets deposited subendothelially here, hitting the basement membrane and the podocyte. Okay, so that is what we had discussed. Now, the complex initially gets deposited subendothelially, causes complement activation, causes damage there. Now, for some reasons that are not very clear, after that they dissociate and then reassociate subepithelially. Okay, and this is actually something that is not really clearly understood. It's likely got to do with the physicochemical properties of the antibodies, but we don't really know. But the thing is that the antibodies eventually form subepithelial humps. Okay, and these are not to be confused with the subepithelial antibodies and humps that you get with membranous GN. Okay, there it's a relatively chronic process, and there is basement membrane deposition in between those humps. Here, that is not the case. Here, there is clear endothelial damage. Okay, subendothelial deposition is the initial thing, and then after that, there is a dissociation and reassociation of these antibodies subepithelially. But yes, technically, when I do immunohistochemistry, I will find the antibodies having been deposited subepithelially. Okay. Now, as I discussed earlier, the precipitants of anti-GBM syndrome are smoking, infections, and stress. For post-streptococcal, it is your pharyngitis and impetigo, and the serotypes of streptococci that are associated with this are very specific and rather easy to remember. Okay, it's 1, 2, 3, and 4. Okay, and then instead of 5, what we do is we multiply 3 into 4, so that becomes 12, and that's the same as the first two numbers here. And then finally we've got 5 squared, that is 25, and 7 squared, that is 49. Okay. A routine question that is asked is which are the impetigo serotypes that all can also cause pharyngitis. So that is 2 and 49. Every other impetigo associated PSGN causing serotype is actually is not associated with pharyngitis related PSGN. Okay, so other serotypes being 47, 57, 55, and 60. Again, factual things. If you can remember it, remember it. I don't. Um, then, depending on the age of presentation, as I've already discussed, anti-GBM syndrome can develop early in life, that is late 20s, and it can develop after 60 years. And as we have already discussed, early in life, there is a male prediction or predisposition preponderance, whereas later in life, it is equal. Now, early in life, it usually presents with a pulmorenal, so-called pulmorenal syndrome. That means diffuse alveolar hemorrhage as well as glomerulonephritis. And later in life, it actually presents with a subacute to chronic renal dysfunction. And often it is silent and therefore not diagnosed in time. And by the time the patient is diagnosed, they have CKD. So that is associated with a poor prognosis. As we've already just discussed, the precipitating infection in case of post-streptococcal GN after pharyngitis occurs after around 1 to 2 weeks or 7 to 14 days, and after impetigo occurs later. Uh, Earliest is 2 to 4 weeks. Actually, it's around 4 to 6 weeks. Okay, so this is 4 to 6 weeks. Okay. Now, after that, you develop a nephritic syndrome, and obviously, the nephritic syndrome typically lasts for more than 2 weeks. Typically, it is a very uncomplicated nephritic syndrome, whereas here the patient goes into rapidly progressive renal failure, RPRF. Okay, so these two are very different in terms of how they progress and how what their prognosis is like. Okay, so as you can see, 99% of post-streptococcal GN cases have complete recovery, and in fact, almost post-infectious and para-infectious GN recover remarkably well if you treat the primary infection. So that warrants specific diagnosis as early as possible. In case of IgA vasculitis, as you can see, the primary deposition is submesangial, that is mesangial because of the physiochemical properties of IgA that they form dimers. Now, the what exactly is happening is a little interesting. So then there is epithelial inflammation, as I'm sure everyone knows, and we'll get into the details of this later also. Epithelial inflammation, whether it is infective or non-infective, results in production of epithelial plasma cells under the effects of TGF beta, producing your uh, immunoglobulin alpha 1, okay, or IgA1. Now, IgA1 is normally a glycosylated antibody. So, its hinge region typically contains a O-linked or oxygen-linked glycosylation site. Okay. Now, this glycosylation in these particular people is slightly abnormal. So, because of that, that exposes a N-style glucosamine residue in the hinge region of IgA1. Now, again, just like we saw with your the NC1 region of alpha 3 chain of collagen type 4, here also this kind of IgA1 is not normally expressed in the human body. So, because it is not, you end up developing a immune response against it. So, that immune response may be IgM or IgG antibodies, and that then causes a combination of IgA1 antibodies. This would be the IgA1 antibody with a abnormal hinge region. So you have a hinge region here that is slightly abnormal. So there is abnormal O-linked glycosylation, and against this you have Ig G. I'm drawing for simplicity. IgG antibody that is formed. So you got a dimer here of two separate antibodies that is formed, and this dimer then gets deposited because of the physiological or the physical and chemical properties of the antibody complex that has been formed, gets deposited in the mesangium, where it causes alternate complement activation, because it's it's IgA1, and that results in a nephritic presentation more than a nephrotic presentation, although there is some minority of patients do develop nephrotic presentation also. Now, the important thing is this kind of epithelial inflammation can happen due to a lot of secondary disorders. Okay, so you can have decreased metabolism. So IgA1 is produced by epithelial plasma cells, but it is metabolized by the liver. Okay, if you have a problem with the liver, like you have a chronic liver disease or you have any other liver disease, most commonly alcoholic liver disease, you may not be able to metabolize that IgA1, and as a result, serum IgA1 levels may be very high. On the other hand, IgA1 levels there may be increased production. IgA production may be increased because of disorders with negative type 1 interferon signatures. That includes your spondyloarthritis, like your ankylosing spondylitis and relapsing polychondritis, as well as it might be increased due to chronic epithelial inflammations. Such inflammation may be may be occurring in the lung, it may be occurring in the GI tract, it may occur on skin and conjunctival tissue. Such inflammation may be a directly inflammatory process, or it may be secondary inflammation as part of a neoplastic process. And uh, in this vein, in the lungs, chronic inflammation happens with bronchiectasis and interstitial pneumonia. In the GIT, it happens with Crohn's disease. In the neoplasms in the GIT, like in adenocarcinomas, can be relatively slow growing and therefore also have this problem. They can also produce TGF beta as a paraneoplastic process. Then you can have skin and conjunctival IgA1 production because of leprosy and Sjogren's syndrome, as well as neoplastic Th2 polarization and mycosis fungoides resulting in IgA1 production. So these are the disorders that that can cause secondary IgA1 production and therefore result in your patient having IgA IgA nephritis. Incidentally, recently I had a patient with Sappho syndrome or synovitis with acne with pustulosis and osteitis, who had not undergone an MRI of the sacroiliac joints previously, and had presented to me primarily with long-standing history of chest pain and your basically pain during in the along the costochondral junctions during deep inspiration, as well as clavicular pain in the past, and then over multiple years, over 20 years, and then subsequently developed inflammatory back pain. Now, this patient was suspected to have axial SPA, but never, for some reason, underwent proper investigations. Uh, his HLA-B27 was done, and he was diagnosed as having HLA-B27 negative sacroiliitis. Okay, so something like axial SPA. However, interestingly, I reviewed his reports and I found that at one time he had developed discrete palpable purpuric lesions over his lower limbs, which were biopsied elsewhere, and then there was definite evidence of IgA1 deposition there. Okay, alluding to the possible underlying diagnosis of axial SPA, so axial spondyloarthritis. So this is something that can be a clue to underlying axial SPA, particularly in such long-standing cases. This patient had been misclassified as having fibromyalgia for a long time and therefore had not received appropriate therapy. And as you know, in the present day, axial SPA is a eminently treatable disease. Okay, with your anti-TNF agents. So that is something that we mustn't mix. Now, let's talk about the clinical presentation of IgA. So, there are two major forms of presentation. One is you could have a macroscopic hematuria, which happens again and again, and you could have a persistent microscopic hematuria. Now, the problem with microscopic hematuria is that the patient doesn't realize that they're having hematuria, and the problem continues happening again and again. Whereas macroscopic hematuria is usually a self-limited process which doesn't really require any other, any further treatment or investigation. Now, when you have microscopic hematuria in patients with IgA1 vasculitis, you end up essentially, having a patient who's got this chronic glomerulonephritis, which never really subsides. Okay, so as a result, it often presents as a patient who's already progressed to chronic kidney disease, and therefore, microscopic hematuria, interestingly, is epidemiologically associated with a poorer prognosis than macroscopic hematuria. Now, an important point that I wanted to highlight was that see IgAL1 levels in the tissue are relevant. They are not relevant in any other location. So in tissue, that for example in renal biopsy or in specifically in renal biopsy rather, you have almost 100% sensitivity. Okay, but in skin biopsy, the sensitivity then falls to 15 to 55%. Okay, so having not having very strong IgA1 product, deposits, or while you still strongly suspect IgA1 vasculitis, that is IgA nephropathy, in skin, skin is not the best tissue to sample for this. Okay, and may not actually be that diagnostically useful, other than in the case that I had, some cases like I discussed just previously. Now, the serum values are slightly worse. So they are positive only in 20 to 50%. So this I never do. I never send a serum IgL1 level. For two reasons. One is the sensitivity is as such low, and also, what has had to happen has already happened. So there's no point in assessing the serum levels. Now, the natural history of IgA vasculitis. Uh, Now, this is actually quite variable. It is similar to what I described for lymphocytic interstitial pneumonia in cases of interstitial lung disease. So, about a third of patients have complete resolution. About a third, that is around 25 to 30%, progress to kidney disease, chronic kidney disease, but this progression is rather slow. Again, over 25 to 30 years. So, it's easy to remember because it's 25 to 30% over 25 to 30 years. Okay, it's very slow progression, and very rarely, the other third of the patients have a don't progress to CKD, but they don't have a complete resolution also. Okay, now very rarely the patients develop rapidly progressive renal failure, which would be defined as very rapid product progression to significant renal failure. Uh, Basically, an persistent bad azotemia or worsening azotemia, it is after 1 week or so of treatment, or obviously requirement of dialysis or renal replacement therapy in that much time. Again, this is a topic in itself. We'll discuss that in detail later. So AKI or AKI plus AKD in a patient with IgA nephropathy can be one of two things. It could be due to that gross hematuria causing hemoglobin pigment cast formation within the tubules and causing blockage. It could also be due to proper crycentric gene. We saw that even type 3 hypersensitivity causes type 2 rapid crycentric gene. So that also could be there. And the only way to really differentiate this is to actually do a renal biopsy. Okay. Now, importantly, even when you have just a pigment cast nephropathy, 25% of such patients have a residual loss of renal function, and in that situations, gross hematuria may persist for more than 10 days. Okay, so hematuria and its relationship to prognosis in patients who have IgA nephropathy is slightly unusual. One is microscopic hematuria is epidemiologically associated with worse prognosis because the patient doesn't come to you in time. Uh, and macroscopic hematuria lasting for more than 10 days also can result in pigment cast nephropathy, which may cause in one out of four such patients would cause persistent renal dysfunction. So the long-term renal outcomes in such patients they depend on the exact situation. Now, broadly speaking, the poor prognostic features in IgA nephropathy are male, gender, and older age, and absence of gross hematuria, as I've already discussed, or gross hematuria for lasting for more than 10 days, presence of objective evidence of significant renal damage, that is proteinuria and hypertension. Now, particularly proteinuria that is persisting for longer than 6 months is a single strongest risk factor for progression to renal disease. And actually, that is what we target while treating patients with IgA nephropathy. Um, since this is not this is a diagnostic discussion, I'm not going to go into that in detail at present. Now, in the renal biopsy, obviously, naturally, the presence of significant pre-existing CKD, that is extensive, or presence of concentric or crycentric GN, or the presence of extensive endocapillary your proliferation, all indicate very severe inflammation, and therefore naturally indicate that the patient or indicate end stage renal disease, and therefore naturally have poor prognosis. Okay. Now, importantly, these risk factors account for less than 50% of the risk of poor prognosis in IgA nephropathy. So actually, you really cannot predict with IgA nephropathy. It's one of those diseases where patients with poor prognostic, multiple poor prognostic factors may actually have show significant improvement, and patients with very few poor prognostic factors may have a very poor clinical course. Now, coming to the last part of today's of this discussion, that is the sequelae of glomerular damage. So, I've divided them into two. What happens when there is acute glomerular damage, and what happens when there is chronic glomerular damage? Okay, and this essentially is in a way the path that leads to CKD. Okay, and how glomerular disease leads to CKD is what I'm going to try to describe. So, in case of acute glomerular injury, you have glomerular injury that is resulting in your inflammatory mediators getting released into the glomerulus. There is a damage to the basement membrane, to the endothelium, and that gets released into the Bowman space. Because of that damage to the basement membrane, there is some leakage of protein. Okay, but again, this is not the same as what we discussed with membranous GN or with your minimal change disease. The structure of the basement membrane is still intact. The podocytes are still there, so the negative charge is still there. Okay, the proteinuria is therefore not usually that florid. However, what that results in is all of these inflammatory mediators getting, filtered, or you wouldn't call that filtered, escaping into Bowman space. And once they've entered into Bowman space, they then progress to your to the lumen of the tubule, and within the lumen of the tubule, they activate your pathogen recognition receptors and damage recognition receptors, your TLRs, CLRs, RLRs, and LLRs on the tubular epithelial cells, not NLRs. NLRs are in cytoplasmic, but all the others. Okay, and that results in tubular cell death, and that tubular cell death, as well as that secondarily results in desquamation of these tubular epithelial cells and obstruction of the lumen of the tubule. It also results in those corticomedullary junction glomeruli, results in decreased production of renin. And this is rather interesting because there is decreased renin production acutely when there is acute glomerular damage. This decreased renin production, we know renin is responsible for production of angiotensin 2 eventually. Okay, so angiotensin 2 is reduced, so that results in your now that the serum levels of angiotensin 2 maintain the level of constriction of the efferent arteriole, that is the arteriole that is that is carrying blood away from the glomerulus. Okay, so that then dilates. Because the efferent arteriole dilates, the back pressure into the glomerulus is decreased, and therefore there is a decrease in the glomerular capillary hydrostatic pressure. And that decrease in glomerular hydrostatic pressure results in decreased GFR. Okay. Now, so what is happening here is, say this is your okay, so I'll put it here. So say this is your glomerulus, the Bowman's capsule, and this is your afferent arteriole, the capillary tuft, and then I'll write in blue, the efferent arteriole. Now, what is happening within the capillary tuft is there is a decrease in the hydrostatic pressure within the capillary tuft. Okay, and in addition to that, because of your tubular obstruction, there is a obstruction into the tubules here. So as a result, there is a increase in the hydrostatic pressure within the Bowman space. So the pressure within the Bowman space, the hydrostatic pressure is increased. So obviously we know this is the pressure that causes filtration, and Bowman space pressure is what is usually zero, and therefore that does not impede filtration. So because of these two reasons, you have a reduction in the effective filtration pressure, and as a result, the ejection frac, oh sorry, not the ejection fraction, the glomerular filtration rate falls. Now, there is another reason that this happens because tubular inflammation also results in interstitial edema. So, this interstitial edema extrinsically also compresses the tubule. So, not only is the Bowman space, the tubular lumen getting blocked by desquamating epithelial cells, it is also getting compressed from outside. Okay, that also contributes to the increase in the hydrostatic pressure within the Bowman space. Okay, so this results in increased hydrostatic pressure in the Bowman space, and both of these things together result in a decrease in GFR. Now, Systemic autoimmune diseases contribute to this glomerular injury predictably, and they also contribute indirectly to interstitial injury. And we'll be discussing this in coming sections in this series on interstitial inflammation. And this interstitial inflammation can also directly cause PRR and damage related receptor activation on tubular epithelial cells. When this damage becomes chronic, what ends up happening is slightly different. So when there is as time goes by and the inflammation has caused significant damage in the glomerulus, there are some glomeruli that just don't have enough, effective glomerular filtration. So as a result of that, there is decreased distal sodium delivery to the juxtaglomerular apparatus of these neurons, these affected neurons. That causes RAS activation. Okay, because the tubular cells have now healed and they are coming back to producing renin, and however the glomeruli are damaged beyond repair, many of them, and because of that their distal sodium delivery is decreased, and resultantly because of that there is a RAS activation. Now this RAS activation causes, again, now in this situation the efferent arteriole is constricted. Okay, and we discussed in the last discussion that when such a thing happens, the afferent arteriole dilates. So the afferent arteriole is dilated and the efferent arteriole is constricted. Now, what would this do to the glomerular hydrostatic pressure? So this is your Bowman space, and again, this is your afferent arteriole. This is your glomerular capillary tuft, and this is your efferent arteriole. Okay, and now what is happening is that this is dilating outwards. Okay, and this is constricting. That is, the efferent arteriole is constricting. Now, when this dilates, more blood enters into the glomerular capillary tuft. But when this constricts, that gets backed up, so it cannot go out. So, as a result of this, what ends up happening is that there is an increase in the capillary pressure within the glomerular capillary tuft. Now, this is the exact opposite of what happened in the acute glomerular damage stage. Okay. Now, in addition to that, you also have something very interesting happening. That is, you have a persistent damage to the basement membrane and eventually even to the podocytes, which have been trying to compensate, but because of this chronic RAS activation are now on failing. There's also local signaling due to hepatocyte growth factor, IGF-2 production, and TGF beta. Okay, and we'll talk about this later when we discuss CKD in detail. But yeah, that happens here. So because of this, there is podocyte dysfunction, and because of that, there is persistent proteinuria. So there is increased intragranular pressure. There is podocyte dysfunction, so therefore the basement membrane is no longer very good at its job. So as a result, there is persistent proteinuria. Now, this process is what we call glomerular sclerosis, and see that glomerular sclerosis is as directly caused by RAS activation and by intraglomerular hypertension. Okay, now this persistent proteinuria results in signaling to the tubular epithelial cells that are there downstream of this damaged glomerulus to convert from epithelial cells to mesenchymal cells, something that is called epithelial to mesenchymal transition. Okay, and this is actually a central component of your progression to chronic kidney disease. And that's how a glomerular injury eventually results in tubular damage, or rather tubular uh, disassembly, it would be a better way to describe it, and that results in a development of these epithelial cells getting converted into fibroblasts and then myofibroblasts in the interstitium of the kidney, eventually resulting in interstitial fibrosis, okay, within the kidney, resulting in vascular distortion of the architecture of the medulla of the kidney, and as a result of this loss of tubules as well as vascular distortion, secondary tubular dysfunction. So here the tubular dysfunction, the tubules are not getting obstructed. Okay, there is tubular functional dysfunction. Okay, and there is a decrease in the number of functional tubules that are there in the glomeruli, and or the number of glomeruli having functional tubules, and there is also a decrease in the blood supply to these tubules, resulting in their further functional deficit, so resulting in eventually your chronic progressive chronic kidney disease. So importantly, these renal parenchyma, when we come to the histopath, we'll see that these fibroblasts are diffusely present in the interstitium associated with atrophic tubules. So, where are these fibroblasts coming from? So, this is something that is rather interesting. 50% of the fibroblasts that are there on that you might see in a biopsy in the interstitium of a patient with CKD are resident fibroblasts. 35% of them are actually bone marrow derived cells called fibrocytes. Okay, and 15% are epithelial to endothelial mesenchymal epithelial or endothelial cells that have de-differentiated into mesenchymal cells, and these are what are present. So as I described already, hepatocyte growth factor, hepatocyte growth factor, AGF2, TGF beta, as well as platelet derived growth factor, hypoxia inducible factor 1 alpha, and FGF2 are also responsible for further activation of these fibroblasts, and these are inhibited by these two distinct factors, that is hepatocyte growth factor and they are bone marrow morphogenetic protein type 7 signaling. uh, this is just experimentally in situ, probably this is not the case. Okay, so but this is something that is given in Harrison 20 seconds, so that is something that I need to highlight. Uh, I hope this much is clear. The last section, two sections, may not hold much clinical relevance at the present moment, but you'll see that, see, I've described the natural history of your anti-GBM, IgA, post-streptococcal gene, as well as to some extent even subacute bacterial endocarditis, although I've not gone into SLE. But the how these diseases progress, how that natural history actually comes to be, is because of these biological processes that I've described in the last three slides in this discussion. So the rest of this I'll be picking up and we'll talk about in our discussion on chronic kidney disease. Till then, I'll take a leave and basically highlight that now what we've done is we've understood how different pathomechanisms result in a common clinical presentation, that is nephritic syndrome, but there are different histological morphologies which I have implied strongly based on our understanding of the pathomechanisms, but I'll be deriving that formally one discussion from now. Then we have compared and contrasted between the causes of nephritic syndrome that result in subnephrotic range proteinuria. I have not discussed those causes that cause nephrotic range proteinuria, so we'll just cancel this out. Okay, that is MPGN and plasma cell dyscrasia related. We have compared and contrasted between the etiological diagnosis that cause nephritic syndrome without nephrotic range proteinuria. That is, we've compared Goodpaster syndrome, post-streptococcal GN, IgA nephritis, subacute bacterial endocarditis, as well as SLE, lupus nephritis. We have also reviewed the detailed illness scripts of Goodpaster syndrome as well as IgA nephritis, and we've understood what are the acute versus chronic sequelae of injury to the glomerulus. And I have given you the shown you the path to how that leads to CKD. Okay, because it seems a little odd that one compartment getting affected in the kidney would result eventually in the entire kidney losing its function. But how that is and how that results in a mathematical mechanistic avalanche is a discussion for another day, but a rather interesting discussion. So that brings us to the end of this topic, which is rather long, but I hope you watched till the end. And I'll see you in the next discussion where I'll be discussing nephritic syndromes with nephrotic range proteinuria. So thank you, and I'll see you next time.